Dalia Chatterjee. Subject is Glimins hydrochloride. The next generation Glimins management of P2 diabetes mellitus. Supported by La Renon Healthcare Private Limited.
Good evening, ladies and gentlemen. So today I'll be talking about a very novel anti-diabetic agent which is known as Glimins. And imiglimin is one of the prototype of this Glimin. So dysfunctional mitochondria are the pathological basis for diabetes. And mitochondria and diabetes, they go hand in hand because mitochondria is the powerhouse of the cells, and we know that mitochondria results in the generation of ATP, which is vital for us, for all living organisms. And they are also the key regulator of glucose-stimulated insulin secretion in the pancreatic beta cells. During the past 2 decades, evidence has shown that mitochondrial function is closely related to various facets of diabetes: pancreatic beta cell dysfunction, insulin resistance, obesity, and vascular complications related to diabetes. So mitochondria and diabetes, this is a new concept, novel concept, which we are here to embrace. And here you can see that the 3 major functions of mitochondria in regard to energy metabolism include ATP production, generation of reactive oxygen species, and apoptosis. Pathophysiology of mitochondrial dysfunction in diabetes. Here you can see mitochondrial dysfunction is central, and genetic factors in combination with environmental factors lead to mitochondrial dysfunction. Here the genetic factors, you can see that the mtDNA, that is the mitochondrial DNA mutations, nDNA mutations, that is the nuclear DNA mutations, other common genetic variants, environmental factors in terms of obesity, intrauterine malnutrition, other environmental causes, and ultimately this culminates into beta cell dysfunction and insulin resistance as a result of mitochondrial dysfunction. And beta cell dysfunction, you can see it leads to impaired insulin secretion, beta cell failure, and insulin resistance is decreased. MT, that is mitochondrial DNA, decreased oxidative phosphorylation system, increase in L-carnitine acyl transferase, and increase in DAG, that is diacylglycerol, and increase in the ceramide components. Ceramides are responsible for programming the cell depth of any cells in our body, and similarly it leads to increased level of apoptosis of the beta cells of the pancreas, culminating in type 2 diabetes mellitus. So mitochondrial dysfunction in diabetes, as you can see, is the key theme which is being much researched nowadays, and this leads to all the pathophysiologic defects in type 2 individuals that we come across. Here the comparison of imiglimin, which is the class reflection of the Glimin group of medications, and this is the comparison with other major therapeutic classes. Biguanide, that is metformin, you can see the clinical HbA1c lowering effect to the tune of minus 0.7% to 1.2%, and other key attributes and liabilities as possible risk of development of lactic acidosis, GI adverse effects, sulfonylureas or glinides. There's 1% reduction in HbA1c from the baseline. It leads to hypoglycemia, weight gain, and increased risk of CV mortality. SGLT2 inhibitors, HB lowering effect is 0.6% to 9%. Renal and CV benefits: mild weight loss, reduced glycemic efficacy with renal insufficiency. Again, the HbA1c lowering effect is to the tune of 0.44% to 1%. GI adverse effects is the outcome. In most cases, GLP-1 receptor agonists, you can see that it leads to a HbA1c lowering effect of 0.8% to 1.4%. And there is weight loss and CV risk reduction. DPP-4 inhibitors, 0.6% to 0.8% HbA1c lowering effect with potential loss of efficacy after 9 to 12 months. Now we have the glitazones, 1 to 1.6% HbA1c lowering effect with resultant weight gain, edema, increased bone fracture risk. Finally, it is imiglimin, which modulates mitochondrial function. It increases ATP synthesis as also NAD synthesis in the islet cells, and it increases glucose-stimulated insulin secretion, that is, it increases GSIS, which is a very important pathognomonic outcome related to the use of Glimins, and it augments the action of insulin also. So this is the imiglimin and metformin. You can see the two molecules. They have this dimethyl combination, and so it has to a certain extent a biguanide moiety, as you can see over here, between metformin and imiglimin, and this helps in bringing about certain characteristics of metformin with whose use we are very familiar of. But obviously there is a difference in the sense of less development of lactic acidosis with its use. Group of hypoglycemic drugs for the treatment of patients with type 2 diabetes mellitus, and all the studies and clinical trials have taken place in Japan, and here you can see it targets the two main pathophysiological defects in type 2 DM. One is it increases the insulin secretion in response to glucose, unlike sulfonylureas, which is in terms of independent of glucose, and it improves the insulin sensitivity. So it is a new promising molecule with an effective weapon in the treatment of type 2 diabetes. It increases insulin sensitivity, decreases gluconeogenesis, increases the beta cell function. It increases the mitochondrial function, decreases oxidative stress. So it is a very new, promising and effective weapon in the treatment of type 2 diabetes. So this is an illustration of a cell in the beta cell, and here you can see the cytoplasm part, and one part is the mitochondria. So glucose enters the cell by the GLUT2 receptor, that is the glucose transport protein, and by the action of the glucokinase, which is the rate limiting enzyme which converts glucose to glucose 6-phosphate, which is converted to pyruvate. Pyruvate enters the mitochondrial cell, and with this in another pathway you can see the nicotinamide being converted to NAD, and this pyruvate and NAD, it increases the ATP level. So more ATP is being generated, and there is a ATP-ADP ratio is increased, and it leads to membrane depolarization. How? Because ATP sensitive potassium channel is being stimulated, and this leads to efflux of potassium, and ultimately that leads to membrane depolarization, and this leads to more calcium influx into the cell, and ultimately there is exocytosis of the insulin granules, leading to increased insulin secretion. So this is the very micro method of this is the very illustration which depicts the micro means of how insulin is being secreted, and how mitochondria plays a very pivotal role in stimulating insulin secretion from the granules through the method of exocytosis. Effects, amplification of glucose-stimulated insulin secretion, as I said, that is GSIS, and preservation of beta cell mass, enhanced insulin action, correction of mitochondrial dysfunction, a common underlying element of type 2 diabetes pathogenesis, and reduction of reactive oxygen species production, and increase in the mitochondrial DNA synthesis. So here you can see that these are various publications that imiglimin exerts favorable effects on pancreatic beta cells, improving the morphology in mitochondria and increasing the number of insulin granules. How it differs from current treatment options, as you can see, it targets the different elements of the disease pathogenesis by reducing hepatic gluconeogenesis, indirectly and directly promoting insulin secretion, promoting renal glucose excretion, and improving peripheral insulin resistance. So overall, imiglimin stands out by exhibiting this dual mechanism on both glucose-stimulated insulin secretion, which has been highlighted in the preclinical studies on diabetic subjects, and insulin sensitivity in muscle and liver in various preclinical models associated with a preclinical cardiorenal benefit. So this is again a very interesting slide, but very crowded slide. So overall, it is based on three major mechanisms of the Glimins Act. Number one is it improves the peripheral insulin resistance. That means it helps in the uptake of glucose by the muscle cells. It inhibits gluconeogenesis so that the hepatic glucose production is decreased, and it also stimulates insulin secretion, which is glucose dependent. So these are the three pathognomonic features of the Glimins, which is outstanding in terms of other drugs which are being used in the treatment of type 2 diabetic subjects. So imiglimin, this is the first in class with potential differentiated benefits. You can see, as I've already said right now, insulin secretion increase, glucose production, glucose utilization, glucose excretion, benefits on disease progression and complications in terms of CV complications and disease progression. So it's a mitochondria targeted drug for diabetes. It improves glucose tolerance due to a variety of mechanisms, including decreased hepatic lipids, improved insulin signaling in the liver and muscle, and ameliorated beta cell function, protective for end organs, particularly kidney and heart. Again, this is based on mitochondria about it, and the energy metabolism, and ultimately the oxidative phosphorylation, which leads to the generation of NAD, and this comes into the mitochondrial respiration cycle. So this is again a differentiated mechanism action in the mitochondrial enabling glucose plus benefits. Again, it's a repetition. So in a gist, we have just learned that the three pathophysiologic mechanisms based on which the action of imiglimin is considered. And here, this is a very interesting slide which shows that imiglimin increases succinate oxidation. Now, succinate is a byproduct in the TCA cycle, that is the Krebs cycle, and it decreases the mitochondrial reactive oxygen species, that is ROS production, and reduces the hepatic lipid content. So, succinate helps in shortcutting the generation of ATP as compared to the total TCA cycle phenomenon, because we all know one molecule of glucose leads to the generation of 30 to 38 ATP molecules. So this is how the ratio is calculated, and obviously imiglimin has a very gratifying effect in combating this pathophysiological problems or dysfunction that arises out of mitochondrial dysfunction. Imiglimin protects the beta cells from apoptosis by decreasing oxidative stress. And this is the PKPT oral drug, 500 mg to 1000 mg, twice daily dosing, very low protein binding, hardly it is 1 to 8%, very low hepatic metabolism and urinary excretion in unchanged form, and there is no drug-to-drug reaction and no food effect. And imiglimin, beyond being anti-diabetic, it has also got a renoprotective action, and this mechanism you can see again related to mitochondrial, at the mitochondrial level, by improving the mitochondrial function, by increasing the mitochondrial density and function in the renal cells, alteration in oxidative phosphorylation chain, and reduction in complex 2 activity and reduction in ROS generation from complex 2. Now these are very jargons, I must say, but what is the advantage for kidneys here? Metformin not recommended when the eGFR is less than 30 ml per minute. Glycoside, glibenclamide, similarly 30 and 60 alpha glucosidase inhibitors, no data. Gliptins, eGFR 30 ml per minute. Dapagliflozins, obviously now EMPA has come down to less than 30 ml per minute. Imiglimin can be used up to eGFR less than 15 ml per minute. And the dosage is 500 mg twice a day for patients with eGFR between 15 to 45 ml per minute, and 500 mg with a longer dosing interval for those with eGFR less than 15. And what is the advantage for the heart? It has got CV efficacy. Yes, it has shown that in HFpEF, that is in heart failure with preserved ejection fraction, imiglimin showed positive effects on cardiac abnormalities. And this is the risk of lactic acidosis with imiglimin is lower as compared to metformin. And this is the clinical data. There has been clinical trials, particularly based in Japan, and the efficacy and safety of imiglimin in Japanese patients with type 2 diabetes. This is a 24-week randomized double-blind placebo-controlled dose-ranging phase 2b trial. Let us see the outcome, the effect of imiglimin versus competitors, that is with other competitors like DPP-4 inhibitors, SGLT2 inhibitors. Comparable with imiglimin, as we can see then in bringing down the HbA1c level from baseline to the tune of 1%. And this is with other competitors like SGLT2 inhibitors, it's just the same. And this is the efficacy and safety of imiglimin as add-on therapy in patients with type 2 diabetes inadequately controlled with metformin, a monotherapy. Let us look directly at the conclusions that addition of imiglimin to metformin improved glucose control and also offered potentially a new treatment for type 2 diabetes, particularly in those individuals whose fasting blood glucose level is never at control when we have to consider using basal insulin. So this is again, imiglimin does not induce clinically relevant pharmacokinetic interactions when combined with either metformin or sitagliptin in healthy subjects. This is definitely a very important outcome for us clinicians. And imiglimin phase 3, this is a TIMES trial. There are three kinds of TIMES, 1, 2 and 3, which has taken place in Japan, and this has seen that the primary and the key secondary endpoints were fully fulfilled. And this is again time 2 where HbA1c changed from baseline at 52 weeks, comparable with other anti-diabetic drugs, as you can see over here, sulfonylureas, biguanides, glitazones, AGIs, SGLT2 inhibitors, GLP-1 RAs, as well as DPP-4 inhibitors. So Glimins as monotherapy fares comparatively equal compared to the other agents. And this is the phase 3 times 3, which has been compared with add-on to insulin. And this has also met the primary endpoint with favorable safety and tolerability profile. Clinical data, statistically significant reductions in glycated hemoglobin, that is HbA1c level, and fasting plasma glucose, suitable as a monotherapy or in combination with other classes of anti-diabetic agents, which has been proven by time 2 and 3 study. And imiglimin has structural similarity and mechanism of action similarity with metformin, but imiglimin is truly unique, and this can also be added safely to metformin and achieve further reductions in HbA1c, reductions in the fasting blood glucose level. And there is no significant increase in hypoglycemic events as also in events of lactic acidosis. To summarize, imiglimin acts on the root cause of diabetes by correcting mitochondrial dysfunction. It does not affect mitochondrial respiration, unlike metformin. Add on to any oral anti-diabetic agents, as also to insulin, and it has effects beyond diabetes, that is reactive oxygen species reduction and cardiorenal protection and less lactic acidosis compared to metformin. Thank you very much for your kind attention.
Thank you, ma'am, for your nice presentation.
Lights.
Any question from the audience?
Lights. Thank you very much,
No.
Dr. Dalia Chatterjee and Lareron Pharmaceutical Company for sponsoring this session. I request our chairperson to hand over a memento to our speaker. I will request the organizing secretary, Dr. Sonali Mukherjee, to hand over a gift to our Kulene. শাড়ি দেখলেই সেটা অসাধারণ আর মনে হয় এক্ষুনি খুলেন। মুনকন কনফারেন্স চলছে, সেখানে ডায়াসেস অর্গানাইজিং সেক্রেটারি বলছে কি অসাধারণ শাড়ি। আমি রিকোয়েস্ট করব জাস্ট এ সেকেন্ড, আমি রিকোয়েস্ট করব ডক্টর চন্দ্রশেখর সাপুইকে স্টেজে আসার জন্য। ডক্টর সুমিত খান, ডক্টর সোনালী মুখার্জি। I will request Dr. Chandrasekhar Shapui to hand over a memento to Dr. Sumit Kumar Khan for conducting this, and to Dr. Sonali Mukherjee for conduction of the minute সময় নেব। সারাদিনটা তারা হাত তুলে দিয়েছিলেন, সকলের আশীর্বাদে কেটে গেল আজকের দিনটা। ডালিয়া দি করেছেন, আমাদের ডক্টর পারমিন্দার কাউর একটা সেশন দিয়েছেন, মধুমিতা একটা সেশন দিয়েছেন। আমি সকলের কাছে কৃতজ্ঞ জ্ঞাপন করে